But let's look at some statistics to start with. And whenever we're talking about ethics, we're going to talk about some statistics. And I just updated this. The last 2 days I spent updating this particular program. Here's something interesting. Last year, when we did this program, I think this top number, if I remember, I just fixed it yesterday, was 6.2 million Americans having Alzheimer's disease specific to Alzheimer's. Now it's 7.4 million. Every 65 seconds, another person develops Alzheimer's disease. Now I'm using Alzheimer's. That's not counting all of the other dementias. And then this number also, almost 16 million people in the United States are caring for someone with some type of dementia. That's staggering. And that's from the latest facts and figures from the Alzheimer's disease facts and figures with the Alzheimer's Association. You can find those at alz.org. Again, staggering statistics. So let's start looking at ethical concepts. And those of you, again, that are social workers, nurses, counselors, those of you who work in the field, ethics is one of those things that we're very, very aware of. So these are the four pillars that we're going to be looking at: that respect for autonomy, and we're going to look at how does that relate to dementia. All of this, how does it relate to dementia? We're going to be looking at non-maleficence, where we do no harm. Beneficence, the benefits versus the burdens, where we're going to weigh that. And then the justice, which is the equal care. So the ethical dilemmas, and we're also going to look at, with dementia care, rights, rights of the person who's living with dementia, because they most definitely still have rights and they will continue to have rights. One of the things that's so important whenever we're talking about that person living with dementia is to respect that autonomy while acknowledging this is a progressive disease. This isn't just a progressive disease, this is a progressive terminal disease that eventually, not from the get-go, but eventually is going to affect their capacity to make decisions. So we really, those of us, again, those of you that are healthcare professionals, we can be the ones sitting in on those IDT meetings, those care plan meetings, where we're the one that has to kind of ride that fence. Social workers, counselors, nurses, we're the one that has to sometimes bring up this hard stuff and have these hard talks with families as well. And I know we've got a lot of families on here also. We are the ones that are kind of look this in the face every single day. And for those of you that just joined, yes, you're getting the slides, and yes, it's being recorded. So hold tight. You will get the slides later today. Let me let these last few in. Okay. Let's start with diagnosis disclosure. A dementia diagnosis disclosure. I'll probably get asked this at least once a week. Do we tell them? And if we tell them, do we keep telling them? Now, there's what we've got to keep in mind. Do you keep saying it over and over and over? So we've got advantages and we've got some barriers. Let's think about especially those advantages. Decision making and future planning, I think, is at the top of that. Does the person have the right to know their diagnosis? Yes, they have the right to know their diagnosis so that they can be part of decision making. Now let's look at the barriers. Harm, benefits. If we keep telling a person with dementia bad news over and over and over and over again, it can actually progress the disease. It can push them further into the disease. And then we've got to think about this, and I put this in red. International dementia clinical guidelines recognize that people have the right to know their diagnosis and also the right not to know. Let's talk more about that. The challenge lies in finding the right time and balancing the values of preserving autonomy, beneficence, and non-maleficence. Okay, let's talk about this. A person with dementia, short-term memory is usually affected first. So if we say something to them today and they appear to understand it today, and they can reasonably talk about it today, okay. What if we say it to them today, they are devastated, we say it to them again tomorrow, they are devastated, we continue to tell them, and every single day it's the first time they've heard it, and they're devastated, which means that we're dumping that cortisol. We're doing more harm than good. If someone can hear the diagnosis and start making decisions with you, with guidance about plans for the future, what they want, what their thoughts are about this, that's one thing. But to tell someone over and over and over and over and over again something that devastates them, honest to goodness, is cruel. I've seen it happen. I've also seen it push people further into the disease because the family is insisting on being rational and reasonable with someone who can no longer, they're already past the point of being rational and reasonable. So we've got to take these into consideration. So let's look at that right to know. I've had people call me themselves and say, I've been diagnosed with dementia. I want to learn everything I can. I had a gentleman call me one time and say, I've been diagnosed with dementia. I need you to help me work with my own family. All right. That's somebody who's going into it head first. Let me learn everything I can. But that's not always the case. But getting that formal diagnosis, understanding what's going on, sometimes just out of self-preservation, a person who gets a diagnosis goes into denial. It can't be. Especially if they've seen other people in their family with dementia or if they were suspecting. But I've seen it go the other way as well. That's why we say this over and over in memory care. You've seen one person with dementia, you've seen one person with dementia. You've dealt with one family with dementia diagnosis, you've dealt with one family with a dementia diagnosis. There is no cookie cutter. You're going to hear me use the term trauma-informed person-centered care. Trauma-informed person-centered care. Every single case is different. Now, it can seem very unethical to not disclose a diagnosis. Are we going to tell them the first time? Again, I think this is all it's individualized, but do they have the right to know? Yes. But do we keep telling them? So let's look at the next one. That withholding or limiting, I think that's our key word, is limiting discussion on the dementia diagnosis. Sometimes people can hear it if we don't use the word dementia. Sometimes people can hear it if we change it up a little bit. So let's look at this first bullet point. May be suitable to withhold a dementia diagnosis if disclosing it would cause severe distress or harm to their well-being, particularly if they lack the capacity to understand or, here's a key word, cope with the diagnosis. Understand or cope. Now, I've seen this happen where families want to say it louder and slower like they're going to make them understand. Part of the brain that is damaged early in dementia, in all the dementias, is executive functioning, the ability to be reasonable and rational. So it doesn't matter how slow you say it. It doesn't matter how loud you say it. It doesn't matter how many times you say it. It's not going to make them be rational. Now listen to this term, inappropriate redisclosure. Inappropriate redisclosure. When the person with dementia is unable to understand, it is not appropriate to continue to tell them. Let's look at the next one. Repeated questions from the patient about what is wrong, met with a repeated upsetting diagnostic label. It can heighten their anxiety. It's not helping them at all. And every time we say it, they may go into shock. They're afraid. They're sad. And then those negative emotions, because their amygdala, usually in the beginning of the disease, isn't damaged, and the amygdala's feelings and emotions, they don't know why they're upset, but they're still upset well into the day. Maybe you had the discussion earlier in the day. Let me say that again. Let's say that we had the discussion earlier in the day, and at 6 o'clock tonight, they're still upset, but they don't know why. Because the amygdala holds the feeling, the hippocampus holds the facts. The hippocampus is already damaged. So that fact is already gone. I don't remember I've been diagnosed, but I felt so bad. And especially if I'm told over and over and over and over and over again. So let's look at the last bullet point. It is not necessary or advisable to re-expose an individual to stressful information that cannot be processed and stored. We're doing more harm than good in that case. So as clinicians, we have got to give the diagnosis with compassion and with empathy. And then we've got to go right into validation therapy and validate what's going on for them, because not everybody's going to react or respond the same way. I've seen people have a complete reaction. It's not me, it's you. You're stupid, maybe getting angry, because what's at the root of anger? Fear. The root of anger is fear. But I've also seen people go, I thought this probably is what was going on because my mom has it or had it. So we approach that diagnosis, and it's a process. It's not a one and done. Here's your Aricept, see you in 6 months. And too many times that's what happens. And then what needs to happen, and it just doesn't, and we've got to work on this as a culture, is to provide some resources to that family and to that individual. Instead of, again, we'll see you in 6 months, here's a quote memory med. What if we gave them information to the James L. West Center? What if we gave them information to the Alzheimer's Association here in Fort Worth? What if we gave them information to Dementia Friendly Fort Worth? Hand them some resources. This is going to change their life. It's going to change the life of the family. I beg, beg, beg practitioners all the time, please do not just give them this type of a diagnosis and send them on their way. So I had mentioned earlier the term trauma-informed person-centered care. We've heard person-centered care. We've been using that now for a couple of decades. For the last probably 5 years, we're starting to add that trauma-informed person-centered care. It's where we're doing individual care with every single patient, client, resident, whatever it is that you call the person in your field. And we're looking at each person individually. The person with the diagnosis and their care partners, their families. are all coming into this with different perspectives. There are those, and I said this earlier, that want to know specifically what the diagnosis is. They don't just want the umbrella dementia. They want to know Alzheimer's disease, frontotemporal dementia, Lewy body dementia, vascular. They want to know. There are other people that it's better to use things like memory impairment. That big D word is just too much. So is it okay to say memory impairment? Of course it is. If it's causing more harm to use the word dementia, then let's not use the word dementia. If they're okay with using memory impairment, let's use memory impairment. So when it says PWD on here, that's person with dementia. After getting these slides, we've had a lot of folks come on since I started. You are going to get the slides. You'll get them later. You'll also get a recording. You'll get a copy of this recording. So PWD, the person with dementia, often wants to be involved in the diagnostic conversation and to participate in the decisions regarding their own care. We certainly don't want to talk about them like they're not there. More on person-centered care. This is where we want to respect that individual's goals and their preferences. Look at that family support, because the family's got to start making decisions and doing lots of talking about resources and other areas that are going to be important to that person living with dementia. And when we go in and we look at studies of those that are diagnosed with mild cognitive impairment, MCI, or the earliest stages, I didn't say early onset, so let's clarify that. People misuse this all the time. They get it confused. Early onset dementia is someone who's diagnosed before the age of 65. So a person who's 80 doesn't have early onset dementia. They can be in the early stages of dementia. There's the difference. Early onset is when someone is diagnosed before 65. Early stages are just the early, mid, and late stages of the disease. Because oftentimes families will say things like, my mom's got early onset Alzheimer's. Well, how old is she? She's 80. And what they're meaning to say is she's in the earliest stages. So just to clarify. But the studies show us that people who have mild cognitive impairment or they're in the earliest stages of dementia most definitely still have wants and needs. And what are they? They want to maintain their personhood. Now, I want everybody on here, we've got 94 people. Think about, what if it was you that got this diagnosis? What would you want? And my guess is every one of these is going to be what we would want. I want to be treated as an individual. And I want others to try to see the world from my point of view, try to stand in my shoes, empathy. I want to involve family members and care partners. I want the detailed knowledge of the individual. So I want people to know about me, the specifics of me. This is where the trauma-informed person-centered care comes in. And then to maximize choice. So let's look a little further at that. In dementia care, understanding the concept of a person's cultural background and how it shapes who we are. Understanding language and how we use it. And understanding that care and support. Again, the more we know about the person, the better we're going to be able to provide that trauma-informed person-centered care. If we don't know what happened to someone when they were younger, if we don't know if the person is a combat veteran, if we don't know that there was some type of abuse in their past, all of that in dementia care is going to come up later, because we know that that person with dementia is going through what's called the theory of retrogenesis. This is across the board with dementia, theory of retrogenesis. They're going back developmentally. They're going back in time developmentally. So if they had a trauma somewhere, and I think the statistic now is about 94% of all Americans have had some type of a major trauma, at least one. I think the other 6% probably lied because we've all had something that, in our perspective, qualifies as a trauma. Don't go back through it. It's going to come back up. Now, it may come back up as a challenging expression. Notice I didn't say behavior, I said expression. They're doing the best they can with what remains. What if I don't know that information and I think they're just having a challenging expression, when in reality, it's trauma coming back up? What if I was able to get all of that information ahead of time? Some of the other things that's going on with that person who's just been diagnosed is fear. Fear of dependence, fear of abandonment, fear of being a burden. And fear, we said this earlier, can come out as anger. Fear can come out as anger. If you've done very much studying, or if you're someone who's taught an anger management class, typically at the root of anger is fear of something. Fear of something. So let's look at how do we then instill that sense of hope, framing the diagnosis as an opportunity to obtain treatment. Now, we know there's not a cure for dementia, but especially if somebody has been diagnosed with MCI, that mild cognitive impairment, or they're in the earliest stages of dementia, we have the infusions now that are having some pretty good luck. For those that it works on, it's working all right. It's working okay. And what's going to happen in another 5 years? That's why right now, when we're out teaching about Dementia 101, we combine that with brain health. Because what if we have been diagnosed with MCI, that mild cognitive impairment, but we could push off that turning on over to full-blown dementia for another 5 years? What's going to be available medically? So what are the things I need to start doing to take care of my brain? We have to reassure that person living with dementia that they're going to be supported. We're going to go into this diagnosis positively. We've got to help the families, those of you that are working in this field, continue to do things to promote their health, their well-being, and their independence. We should never, ever give them a diagnosis, give them a prescription, and say, see you in 6 months. What about the family? That is my job here at the West Center, as I come alongside the families. We've got to also take care of these families, because dementia is not something that lasts for a few days, weeks, or months. This is years. And it's not only years for the person living with dementia, it is years for their care partners. So let's start looking at care management, that companionship. Let's start talking about respite care, medications, non-pharmacological therapies, exercise, all the things that we can do to take care of our brains, brain health. All right, let's talk about informed consent. And again, we've got a whole lot to cover in 90 minutes. So some of this I'm going to go through a little quicker than other. Informed consent. Before we get to and define that decision-making capacity, we need to define what is informed consent. To give informed consent, patients need to hear about the condition at hand and understand the associated risk, benefits, and alternatives of each therapeutic option. They've got to be made voluntarily without being coerced, and the patients determined to have decision-making capacity and who are fully informed have the right to refuse treatment, even if refusal may shorten, that's supposed to say life there, made a mistake. So capacity is determined by a clinician based on the decision at hand. Competence, however, is declared by a court. So let's look at decision-making capacity. It's the patient's ability to accept or refuse a treatment. And the physician can evaluate a patient's capacity to make a decision. Competence and incompetence are legal terms, and they imply that a court has taken a specific action. So again, let's a little bit deeper into capacity. Capacity, the ability to make a choice and to understand that information. So decision-making capacity, there's got to be understanding, appreciation, reasoning, and choice. Decision-making capacity is not all or none, and there's often going to be simple decisions that people with dementia can still make. Now, why don't we call it limited decision-making capacity? Because this is a progressive disease. And one of the things that's affected, there's about 36 common symptoms, but one of the things affected, of course, is memory, comprehension, and the ability to make decisions. Some people, one of the first things that shows up is judgment and their ability to make good decisions based on judgment. So capacity, let's look at how it affects that individual's ability to protect their own self-interest. It also creates vulnerability. So let's look at, for example, they may start having some really poor communication skills. And so that's going to then affect their ability to understand the choice. There comes a time in all dementias where what they're hearing, because of the damage, because of the brain that's failing. Here's an example. You or I see smoke coming under the door, and that automatically means danger. It means fire. It means get out. We learned that. This is part of that theory of retrogenesis, kind of going back in time. So a person with dementia could be sitting in a room, smoke starts coming in, and they don't get up because it doesn't mean anything anymore. That makes sense. We learned smoke equals danger. So there may come a time it doesn't mean anything anymore. But everyone's different. Some people that might happen early on, others it might be more middle of the road. That's why we've got to look at each person individually. Let's talk about advanced care planning. And this is something as healthcare professionals, we need to start talking about this early. We need to all really do this, don't we? We don't know what's going to happen on any given day. So we need to clarify our wishes to our family members. Everyone does. Talk about what life-sustaining medical treatment you want in case of a serious illness or something happens at end of life. So we can fill out our paperwork, that POLST, the POLST, portable orders for life-sustaining treatment. It's documents that have preferences. Do you want CPR? Do you want to be intubated? Hospital transfers, artificial nutrition, and you can find all of these online and fill them out. A living will, guidance for care preferences in the event of future incapacity. And what a difference it makes whenever someone has their living will and then the family doesn't have to make the decision. All the family has to do is carry out the decision that's already been made. And then that medical power of attorney. This designates a surrogate decision maker for healthcare decisions if the patient were to become incapacitated. Sometimes people don't want to fill out a medical power of attorney because they'll say, I don't want someone to start making decisions for me. Well, they can't start making decisions for you until or if you become incapacitated. And should someone become incapacitated, we want someone to make our decisions for us, someone that we trust. So our medical power of attorney or our surrogate decision maker. They have got to make decisions, though, based on what the patient would have wanted. They're basically using their judgment to make decisions for someone else. What we're hoping happened is that there were prior conversations about this. And what I found is usually there have been. I get a handful of people who say, we never talked about anything. That's really hard. That's hard to have somebody who's mid to late stage dementia, and I'm sitting with a family member going, I don't have any idea what their wishes were because we didn't talk about it. These are things we've got to talk about. I know it's difficult. I know it's hard, but how do I go into that conversation? Make it about you. And those of you that are healthcare professionals, hopefully this is one of those that you use with families as well. Go into your parents and say, hey, I'm going to start filling out my will, my advance directives, my power of attorneys. Why don't y'all do it too? Let's all do it together. Let's talk about it. I know it's a hard conversation, but let's take 1 hour and let's really talk about our wishes. The other time it can come up is if we go through the death of someone else. Let's say an aunt or an uncle died and they were on life support. And maybe someone says, oh, I don't ever want that. Make sure that doesn't happen to me. And then we have an idea of what their wishes are. But let's talk about it and then let's get it down on paper. Again, you can find these online. You don't have to go through an attorney to do these. You can do this paperwork. Surrogates often are close family members, and they're usually emotionally attached to the patient. So research has found that surrogates sometimes make decisions based on what they want, not on the wishes of the person. So when someone is choosing that MPOA, that medical power of attorney, when you're choosing yours, make sure you choose someone who's going to carry out your wishes. Families will say to me, but it has to be my oldest child. No, it doesn't. It can be your best friend. It can be it needs to be the person who's going to make the decisions you want made. So where do we then involve the person with dementia? Again, let's examine those risks. That's part of justice. Consider the timing and the other factors. Are we going to bring this kind of stuff up at 7 o'clock at night? Or are we going to bring it up at 10 o'clock in the morning? When I used to do assessments on those with dementia, I always did it between 9 a.m. and noon. 9 and noon was morning. The sun is shining. I'm well rested. I've had breakfast. I've had my medication. We don't want it to be skewed in any way. I'm not going to have this conversation at 4 o'clock in the afternoon during a thunderstorm. So involve the person living with dementia as much as you can to help make decisions about their own care. When we're talking to that surrogate decision maker, this would be the MPOA, they need to be educated about the disease process. They need to get educated immediately. I've talked to too many families who say, well, we're just at the beginning of this. I'll start coming to a support group later. No, start coming now. Get in there now. Get into that support group so that you start building your support team. We don't ever want to wait until there's a crisis. Again, those of you that work in the field know, when do we talk with families when they're in crisis? It's rare that I get a phone call or an email where somebody's completely and totally stable. Everything's just perfectly fine. They're going to call when there's a crisis. Let's get them educated before there's a crisis. Offer the books, offer the websites, offer the YouTube pages. Because what I found is lots of times people will hit those YouTube pages at 9 o'clock at night or 10 o'clock at night, and then they start learning. Because the more they know about dementia and the more they know about where this is headed and the progression, it's still going to be hard to make the decisions, but they're going to make informed decisions. So that person living with dementia is going to need a decision maker. And that decision maker has got to be someone who's going to follow their wishes. So let's look at non-maleficence. In the Hippocratic Oath, I will abstain from all intentional wrongdoing and harm. Do no harm. And I know we've got a lot of counselors, social workers, nurses, administration that are on. We are to do no harm. So beneficence, this is where we're going to weigh the benefits of care versus the burdens of care. Benefits of care versus burdens of care. Just about every day, if you work in healthcare, you are going to come across a family member who's having to weigh. We sit on the fence. That's what I say. Our job is we kind of sit on the fence. We're going to help them with this. We're never going to push our personal ever, but we're going to help them with this through education. Through education. So the 4 M's, I'm sure most of you have heard of the 4 M's by now. We've got to know what's important to the older adult. Do they want to stay at home? Would they consider a retirement community or some type of senior living? We need to discuss end-of-life care. And we're going to talk more about end-of-life care. Medication, mentation, cognitive status, and mobility. Mobility is important. Again, put yourself. How important is it to you to be mobile? I think most of us, that's right up there at the top. So let's look at what matters. And I want to show you a tool here. This is a helpful tool. It was developed collaboratively, and it allows the patient to fill out the 4 M's on their own. The what matters, medication, mentation, and mobility. So this is a really good tool to use. And again, you're going to get copies of all of this. And then you can find this as well. We can send you the PDF also. So this is something really good. It's good for us to do too. And it's going to change over time, isn't it? Because what this is at 55 and what this is at 65 and what this is at 75 is just going to look a little bit different. So this is a really good tool to use. Another thing we need to talk about is, where does the person want to live? Where do we want to live as we age? So, new statistic, Home Care Association of America says that, I don't think anybody's going to be shocked by this, 89% of older adults surveyed would like to age in place. Live at home, continue to cook for themselves, continue to clean for themselves, continue to drive. There's a big one that's going to come up. Is that reality? Considering life expectancy. And again, I checked life expectancy this morning, as a matter of fact. In the United States, life expectancy in general was 77.6, I believe. 78.6. Men, 76. Women, 81. United States right now, life expectancy, 76 for men, 81 for women. So we want to stay home, to drive, to cook, to clean, to take care of ourselves. But is that realistic? And is it safe? So medical ethics. As a professional and as a family, We've got to try to allow that older adult some autonomy, but we've also got to make sure there's no harm being done. Fairness and equality to the patient. But what's surprising is statistically, when you look, many people after placement, their mood is actually better. Their social activities increase, their appetite increases, and some people's cognition even goes up a little bit. I've seen people even on that very simple MMSE, the mini mental, their score kind of go up a little bit. Does that mean the dementia's better? No, it means their circumstances, their surrounding is better. So ethical considerations of older adults living alone. Let's look at each of these. Of course, the independence and the freedom, but safety, number one, safety. Another question I get asked at least once a week, how do I know when it's time to place my loved one? We just did a program on this, as a matter of fact. Safety, there's the answer. There's physical and there's emotional safety of the person with dementia, but there's physical and emotional safety of the caregiver as well. Medication management, meals, mobility, family and friends, resources, professional caregivers, and there's that big one, driving. So safety for seniors while living alone, there's some things we have to consider. We've got to evaluate safety all the time. We've got to have a home safety assessment. There's got to be a fall risk assessment and some home modifications. So we go in and we put in some grab bars. We get rid of throw rugs. Maybe we put in some cameras. And again, got to be careful with that. We don't want to be putting cameras in somebody's bathroom, but where are most falls? The bathroom? Ethical. What about the front door cameras, though? Simplifying the phone. This comes up a lot on support group about what do we do about phones, because cell phones, in the big scheme of things, new technology. They may need time where maybe we're just bringing in some help into the home. But do we have that disaster plan? Are they able to call for help if they do fall or get in trouble? And then how much technology are we going to use or put into the home? So first, let's look at medications and meals and modifications. Medication management. Often older adults living alone can have their routine and manage safety while at home, as long as they can do it safely. Taking their medications and they're doing it timely and they're doing it appropriately. Are their prescriptions being filled? Are you needing to come in and set up the medication? But then, are they taking them appropriately? Or do you come in and it's still full? Or do you come in and they've taken too many? For some people, this is when they decide to start bringing in more help, or even placement is whenever they're not eating, or they're eating too much, or they're not taking their meds, or they're taking too much. So a common scenario is there's a cognitive decline and eventual medication errors and events in the kitchen, like leaving the stove on. People living with dementia may be able to live in an apartment, a home, or a retirement community when the deficits are identified and modifications are made. But there's red flags to look for. Spoiled food in the house, weight loss, loss of appetite, only wanting to eat sweets. That's part of dementia. An empty pantry, forgetting to eat, forgetting how to use appliances. Because think about it also, for some people, a microwave's been around forever, but for those of us over probably the age of 50, definitely, I can remember not having a microwave. And I'm going back in time developmentally. What is that thing? Do I know not to put aluminum foil in there? Do I know not to put a fork in there? Red flags on medication. Again, the full pill box, too many pills, disorganized pills, pills are disappearing. What about driving? This is fun. Driving under the influence of age. Driving under the influence of age. Motor function, vision is going to change with dementia, and cognition. Spatial is going to change pretty early on. Ethical dilemma related to aging and driving deserves its own slide. We actually have an entire program just on this because it comes up several times a week, honestly. And it's usually because there's been a crisis. In Texas, drivers 79 and older are required to renew their driver's license in person and pass a vision test. A permit specialist then gives you a driving test. You can actually call the Texas medical evaluation process for driver's licenses. Older adults, especially those over the age of 75, are more likely than young drivers to have contributed to fatal crashes. So it's important to remember that aging itself is not the main problem affecting driving safely, but the medical conditions are, especially vision changes. We know with dementia, one of the first things that happens is it's like they have on blinders. They lose peripheral vision. That's part of driving. Again, we've got an entire program on driving. You can find it on our YouTube channel. And then you also, once a physician diagnoses dementia, the question is not if the person should stop driving, but when they should stop driving, because that is going to happen. Let's move to sexuality and dementia. And we have an entire program on sexuality and dementia. I'll be doing it again in August for the North Central Texas Area Agency on Aging. And I've done this at many, many conferences because it's one of those topics that people don't want to talk about but need to talk about. So let's look at some of the statistics with sexuality and dementia. Sexual well-being is part of aging well. It's not something that goes away. And the World Association of Sexual Health says that sexual well-being is a component of general satisfaction with life and well-being. Sex activates neurotransmitters that positively impacts our brains. So let's look at some statistics. 60% of healthcare workers of dementia patients stated sexuality is not necessary. Sexuality is also often mislabeled as a behavior that someone's having. And many times the staff will overreact, and most of the time it's due to their own sexual history. It's pretty rare that someone becomes hypersexual. I'm going to give you the latest statistic on that in just a minute. But let me give you a couple of examples that I personally have had happen. I had a gentleman who just became very, very flirty in our day program and was always asking me out on dates. Now, think about how to handle this. Those of you who work in the field or you've done our programs, you've heard us talk about we validate, fix, distract. Validate, fix, distract. I'm not going to be reasonable or rational with someone with dementia. I'm going to go to their world. I'm going to use some therapeutic stories. And this particular gentleman who kept asking me out, at the time, I had on a wedding ring, and I would tell him, looky there at that, I've got a wedding ring on. And what he'd say was, your husband doesn't have to know anything. And I'd say, oh, come on, let's get in here and get us something to eat. So I kind of would put it off and make it a funny joke about it. But let's look at some facts here. Just updated this today from Health and Aging. 59% of men and 51% of women in the earliest stages of dementia and mild cognitive impairment report being sexually active. But then 77% report some type of sexual dysfunction. 10% reported feeling sexually threatened. And then this one comes up with caregivers. 17% report feeling obligated to engage in some type of sexual activity. So let's look at consent and capacity as far as sexuality. There's a reason this is in bold. Physical arousal alone is not consent. Physical arousal alone is not consent. The capacity of a person with dementia to consent to sexual intimacy is central to all discussions of sexuality. Nobody should be forced into any sexual or intimate activity that they're not comfortable with. A person should never initiate sexual activity without clear consent. And from Alzheimer's.org, they should demonstrate ability to make choices and appreciate sexual activity. We honor what remains in a person, not what is gone. So let's look at capacity. Capacity is going to change as the disease progresses because there's going to be loss of judgment, there's going to be loss of decision-making ability, and unequal relationships are reason for concern. Capacity has to do with time, person, and place. It's very specific. There has to be an absence of coercion and an absence of delusion. They have to understand what they're doing. They have to understand the sexual activity. They need to also be expressing interest or desire in the act. So when in doubt, the guidelines recommend that the partner be guided by the nature of the relationship and the sexual preferences of the person prior to the onset of dementia. If the person is inactive, all sexual activity should stop. There should be no forcing someone. Sometimes we have to have this discussion with a spouse. So let's look at this quote. As people age, they do not lose their need to intimacy. And in fact, because of losses due to nursing home placement, declining health and lifestyle changes, the need for intimacy may be even greater. An intimate relationship with another resident can enhance self-esteem and well-being. Now, notice they're using the word intimacy. There's lots of things that can be intimate. I had a family caregiver tell me one time that the most intimate time he had with his wife was when he was assisting her at mealtime. He would sit facing her, looking her right in the face, and she'd be looking at him as he was assisting her at mealtime. And it was just between them. And they were sitting very, very close, and they were looking each other in the face, and it was intimate. I've had spouses who want to continue, even after placement, to assist with showers and bedtime because that's what they were doing at home, laying in the bed with their loved one, wrapping their arms around them, and that was their intimate time. With spouses, many times it's the normal part of, I've been with this person for 40, 50, 60 years. It doesn't go away just because there's a diagnosis of dementia. But the most common changes that we will see in sexuality is a decrease in interest. And then we can find false allegations. Now, let's relate this to that trauma-informed person-centered care. I've watched this happen multiple times. My daughter's a LMSW. She's seen this happen as well, working in hospice care, where somebody has sexual trauma in their past. And let's say, here's the scenario. It's the middle of the night, and a male caregiver comes in just to check on a female resident who has dementia. And they're changing them because they're soiled or they're wet. And that person starts to yell rape or starts to say that they were touched inappropriately. A false sexual allegation. Because think of what's happening in their mind. Could they be back at a time where there was trauma? They're misunderstanding what's happening. And then did we, as the care partner, were we telling them what we were doing, or did we just go in and do it? So that's very, very common for that to happen. Now, look at this statistic. I told you I'd give you this one. Only 13% of people with dementia have inappropriate sexual behaviors, and most of them can be managed with behavioral measures. So there's three types of sexual behavior. There's appropriate sexual behavior, there's ambiguous sexual behavior, and there's inappropriate sexual behavior. Only 13% have inappropriate, but of those 13%, here's the statistics. The most common one we're going to see is touching, hugging, or kissing strangers. We hear this a lot, where in the store they're going up and they're hugging people, or they're wanting to kiss, or they're wanting to pat or touch on people. So that's the most common. Second is undressing or being naked in a public place. And you know what that is? Most of the time, it isn't even sexual. Most of the time, I'm hot, I'm cold, I've got a tag bothering me. This bra strap is, but they don't have the ability to say that. But I can take the shirt off, and then it appears that they're having some type of a behavior. You can see some of the others there. The aggressive or repeated sexual overtures, about 40%, exposing oneself during personal care tasks, like an intentional exposure, is about 25%. So how do we respond to that? We're not going to scold somebody or shame or ridicule them. And we can ignore a lot of it. Sometimes family members will choose to start sleeping apart. And we want to use a lot of delay tactics, just like the man who used to ask me out every single day. I would use humor and then food. Validate, fix, distract. I validated what he was saying because I acknowledged it. I fixed it with kind of my funny of, hey, you see that ring right there? And then I distracted him with food. Validate, fix, distract. 4 things we use to distract: food, music, animals, and children. We may have to use medications temporarily, and then we may have to stop unsupervised visits with children or vulnerable adults. All of that will be temporary. Just like everything else with dementia, they're going to turn the corner, move into the next stage, and it will stop. We also want to make sure that we're using touch in ways other than care time. Okay, I used that term, theory of retrogenesis, earlier, going back in time. Well, what do we do an awful lot with, say, children under the age of 5 when they're upset, they're scared, they're worried, they're sleepy? We pick up, we hold them, we pat, we rock, but there's physical touch involved. But as a person with dementia who's developmentally going back in time, many times the only touch they're getting is with showers, changing clothes, toileting, and they crave it. They need to be touched. It can be palm to palm. This is safety. It can be having your arm around them. It can be having your hand resting on them somewhere. We don't ever want to overreact. Don't try to be reasonable or rational, and then redirect. So let me share a couple of things I had happen. I had a son who was probably about 50 come to my office, very, very upset. In fact, he was crying. And he said, Holly, you're just not going to believe what my mom just said to me. And I said, well, come in and tell me about it. Excuse me. And he said, my mom just started talking to me about making babies and how she wanted children with me. And I said, okay, hold on. First of all, where were you? And he said, well, we were in her room. Okay, where were you sitting? We were sitting on the bed. Do you look like your dad? I look just like him. She wasn't talking to you. She was talking to her husband. How do we fix this? Well, is it normal when we go to visit someone to visit sitting on the bed? No. Get out into the living room. Go out into the garden. Bring her a big ice cream, big hellos, little goodbyes in dementia care. Call her mom as you're talking to her, and then you educate yourself. Don't visit in the bedroom. Don't sit on the bed. Come in, calling her mom, big hellos, come with ice cream, go out in the garden. She never did it again. It was educating him. Was she having a sexual behavior? Of course not. No, she wasn't having a sexual behavior. Sometimes we do have to use some medications. Again, it's temporary. Antidepressants can bring down that level of cognitive arousal. Antipsychotics can reduce some of those, quote, acting out behaviors, as can an anticonvulsant. Those memory meds can help with some sexual behaviors. And sometimes we have to use some hormones to reduce testosterone levels. Some other management tips is environmental modifications, watching for signs of either understimulation or uncomfortable clothing. And then there's that behavioral management. Look at these clothes we have here. This is from, these are called adaptive clothing that can have buttons or zippers in the back, look completely like regular clothing. But as you see, this particular one has some buttons or some snaps in the back. The company that these came from is called buckandbuck.com. And we can gently but firmly redirect and distract or guide them away from the source of their stimulation. Now, at a systems level, we have got to educate our staff about this and why it could happen. We do not want to overreact, and that is usually what will happen. We need to assist the staff to understand the need for intimacy and that many times it isn't sexual. So I had this happen many, many years ago. I'm sitting in my office and one of the housekeepers came running in my office. Miss Holly, he's on top of her. He's laying on top of her. I don't know what to do. And I got up and I went in. And again, having worked in memory care for a long time and pretty much mastered the therapeutic story, I walked into the room where indeed they were laying in a bed. They were fully clothed, but they were on top of each other and they were kissing. And I just said, they just called your name down here at the dinner reservations. Your table's ready. Come on, let's go eat. And they both jumped up and off we went down to eat. Easy fix. There was no reason to freak out about it. Now, would that work every time? No. Did it work that time? It did. It worked. Staying calm, walking in, distracting. Basically the same validate, fix, distract. So in the state of Texas, the Health and Human Service System, they do have rights on sexuality and intimacy. So let's just look at this quickly. The residents are entitled to express themselves sexually as long as the expression is not in public, it is consensual, and it does not harm the resident or others. But then the staff member has responsibilities as well to protect the residents from harm, to document the observations, to report the information to the family members, and I want to add in there, let's do some education, and to provide the resident with privacy. So I'm going to share another quick story where I had a woman who moved in. She had dementia. Her husband had just passed away about 2 weeks earlier. So she'd been living with her husband. Her husband had been taking care of her. They'd been married for 60-something years. Her first few nights living at the community, at nighttime, she would get up and go get in bed with men and just curl up next to them. Was she having a sexual expression or a sexual behavior? No. She was looking for her husband. And she found a bed where there was a man, and she got in bed and she curled up next to him. Now, when I called both families to tell them about what was going on, it was the education piece that was so important. So both would understand why she did this. She didn't understand. She'd been sleeping next to that man for 60 plus years, and then he was gone. That was not acting out sexually. So personal care and resident rights. So historically, we think of people with dementia as living with degeneration and loss of their function, memory, mind, and cognition. There's a lot of stigma. So let's look at the rights of the elderly to be treated with dignity and respect. How do we know what's respectful and dignified to the person if we don't know them? So this is, again, trauma-informed, person-centered care. If we work in healthcare in any type of capacity, whether we work at a community or we work in home health or we work in hospice or we work at a clinic or wherever we work, let's gather as much information about our patients, our clients, our residents as possible. And when you're talking to those family members, with compassion so that they will tell you the stories, because these are the stories that many families, those are the family secrets. Explain the education, explain why we need to know. It's going to affect that care plan. I mentioned earlier about the male CNA coming into the room of a woman who had had trauma in her past. Well, if we'd have known of that sexual trauma, we wouldn't have had a male CNA going into that room at night. We didn't know about it. Person-centered care is based on the idea of personhood and that everyone is unique. Other rights to be free of restraints, which is only permitted in very specific circumstances, but we do not want to have to use restraints. We know that sometimes in the hospital they will still do this, but there's also there's physical restraints and there's chemical restraints. They also have the right to communicate in their native tongue. They have the right to complain about their care. And they have the right to privacy. So let's look at the difference when it comes down to independence versus safety. And I'll hear this particular little phrase here. And I want you to think about it. Dignity with risk. Dignity with risk. How often, again, those of you that work in healthcare, do families come in and say, I want you to guarantee me my mom won't fall? Well, can't guarantee that. Just like you can't guarantee they won't fall at home. Now, I use this, again, using humor. We can't bubble wrap them and put them in a recliner. And that's about the only way I might be able to keep them from falling. What kind of life is that? What kind of life is that? We need to have access to the outdoors. We need to be able to move freely around. They don't have to participate in group activities if they don't want to. But what about this? We had an ADON one time who was beautiful at saying this. They do have the right to refuse. They have the right to refuse care. They have the right to say, I don't want to do anything. But do we have the right to stop trying? Well, they didn't want a shower today. They got the right to refuse. They do. But how many times have we tried? How many different people did we get to try? How many approaches did we use? Well, they never participate in anything. Well, is it our approach? What if we didn't say, do you want to? What if we said, I could use your help with? And what a difference we'd see. Because someone has dementia doesn't mean their rights go away. We have to be the person first. So getting to know the person, modifying our schedules, we accommodate the disease. They don't. This is for families and healthcare. We have to accommodate dementia. They can't. They would if they could. And once we know them and we know their story, we're going to be better able to equip them. So how do we remain independent with ADLs? As long as we can. We're going to encourage them to do it for themselves. We also want to make sure we're giving them privacy, and then we have to slow down. Do praises for success. Listen to our voice. I mentioned earlier that amygdala is intact. What does the amygdala? Feelings and emotions and the ability to read feelings, emotions, body language, gestures, tone of voice. So even after the words don't necessarily mean anything, the hippocampus, they can read our body language. What's our voice sound like? What am I conveying with my tone? And if it's not working, we try something else. That's part of we don't have the right to stop trying. Knowing the person, what kind of clothes do they like to wear? What kind of bath products did they use? What time of day? Did they take a shower or did they take a bath? Now, I want you to think about this, everybody individually. We've got about 15 minutes left. But think about this. I don't have dementia. But if I were in the hospital and someone came in and said, I had to take a shower at 6 o'clock in the morning, I am not going to be happy. And I might have a challenging expression, and I don't have dementia because A, I don't take showers, I take baths. And B, I don't do it in the morning, I do it at night. I take baths at night. It's what I've always done. Now, is that going to be important to know somewhere down the road? Of course it is. Now, right now, I have the ability to say, I don't take showers in the morning, I take baths at night. But a person with dementia might have a challenging expression, like a hit, kick, bite, punch, spit, curse word. And they're saying the same thing. I don't take showers in the morning, I take baths at night. Just saying it in a different way. And then are they having an expression? No, that was our approach. Let's look at a study that was done on end of life. What's important at end of life to Americans? Here's a study. Probably no surprise. I don't want to be a burden to my family financially. 87%. I want my medical wishes to be followed through. Again, step back from being a caregiver or a healthcare professional and think of yourself. Don't you want to make sure your medical wishes are followed through? If I say I don't want to be intubated, I mean I don't want to be intubated. I wouldn't want my daughter to intubate me because she wants to intubate me. I said I don't want to be intubated. 81% want to have their loved ones around them. 78% want to make sure they're comfortable with no pain. It's telling us a lot. 77% want to make sure their family isn't burdened by tough decisions. So we got to talk about it. 76% want to be at peace spiritually, and only 46% said they want to live as long as possible. And usually once they're educated, they decide they want quality of life rather than quantity of life. So let's talk in just a few minutes about the myths about death. Myths, death doesn't look like it does on TV or in the movies. You know, we were brought up here looking at Sleeping Beauty and Snow White, and that's just typically not what end of life is. They don't usually just go to sleep. The person with dementia typically doesn't look well at end of life. I do a lot of education about end of life with dementia as a death doula and as a facilitator of our 11th hour team. And the best way to think of it is to compare it to birth. Birth takes a while, and it doesn't always look good, sound good, or smell good. And death in dementia care usually takes a while. We're usually 3 to 5 days sitting vigil bedside, about 80% of the time. And it doesn't always look good, sound good, or smell good. End of life and beginning of life are very, very similar. Ethically, we've got to know the difference between what we have the right to do and what is right to do. And at end of life, this is a really good chart. I know it's hard to see, but again, you're getting copies of all of this. We've got to go back through and look at each of those principles. Talking about DNRs, do not resuscitate. Making sure that a family understands completely what a DNR is, because most do not. I would say probably 8 or 9 out of 10 people that I talk to about a DNR believe that if they signed that DNR, that we would not perform the Heimlich if they were choking. They just simply don't understand what it is. It's a do not resuscitate. We're not going to go in and start chest compressions or shock them or intubate. If we find them, they're already down. Basically, they're already gone. Are we going to go in and start chest compressions? Doing what is good to and the benefit of the patient. And with dementia, again, with early education and continued education, what I have found over the past couple of decades is the more we educate families about dementia, they will come and tell us when it's time for hospice rather than us having to tell them, because they understand. It's just taking the time to do the education and to continue it. And we've got to start that education from the beginning. From the first time you have contact with them, healthcare workers, from the very first time you have contact with them, start educating about this disease. It is progressive. It is terminal. There is still joy to be had. There is quality of life to be had. That's what we're all about, is quality of life. Healthcare, home care, hospice, we're about quality of life. We're going to live well, but we're going to die well. Quality of life. Allowing families to understand what's happening in the brain, why their loved one's going to start losing weight. Using that sentence, a person with dementia doesn't die because they stop eating because they're dying. The body doesn't need the fuel anymore, and the body knows it. So what happens in dementia care if we go in and we put in a feeding tube at end of life, and we're not educated to know that the first system that shuts down in dementia is digestion. And then the sentence that I use with families is, who are we doing this for? Are you doing it for you, or are you doing it for them? It's how we say it. It's with compassion. Is this what they wanted? We looked at the statistics. Now, I didn't see a number on how many people want to die fully intubated on life support in the hospital, because I'm guessing that number is very, very low. Truthfulness in the way that we deliver news, but truthfulness with compassion. We're not going to go in and have these hard conversations with bullet points. Empathy. Family caregivers, by the time they get to placement, home care, hospice, usually have been doing this for a long, long time. And we've got to come alongside those family caregivers. We've got to take care of them too. Here's our summary about those key ethical challenges. And the main one is balancing that patient autonomy with the principles of beneficence and non-maleficence. But I wrote one just kind of in conclusion, and then I think we have time for a few questions. Dementia care, what's different about it? compassionate decisions that honor the person's dignity, values, and quality of life. We have to balance safety with independence, listening with empathy, and recognizing that every single situation is unique and is different. And if we can use respect, collaboration, and grace, we can provide that care. Lots of references on this one. There it is. There's our information here at the West Center, and there's my information if you want to get in touch with me. Those of you that came on later, you are going to get a copy of these slides. You should get them later today, and you will get a copy of this. It will be up on YouTube within the next 48 hours. Let me check the chat. Why is 65 years old the distinct line with early onset dementia? I know it. I know it. I don't know why, but it is. 65 is the line. So 65 years old, if somebody is diagnosed before the age of 65, it's called early onset. Now, that being said, I know somebody right now who's in their 20s and has been diagnosed with Alzheimer's. I also know someone in their 30s that's been diagnosed with Alzheimer's. We also know now that the most common type of dementia before 65 is FTD now, frontotemporal dementia. It's no longer Alzheimer's. That's the most common after 65, but I don't know why that's still the line. That might be something that changes at some point. Can a patient who is told of diagnosis of dementia go through grief? They will go through grief. Absolutely, they will. And just like any of us would, because think about any of us in our life, you may have had it happen before, but not only, make sure you hear this, not only does the person with dementia start going through grief, so does the family. That's why I went and became a grief therapist years ago, because I realized these families are calling it all kinds of other things, but what it is grief. Ambiguous loss. I'm grieving the loss of somebody who's still alive. Think about that. That's what's happening. I'm grieving the loss of someone who's still alive. So it's called ambiguous loss. But then let's add another one on top, anticipatory grief. It's progressive, it's terminal. So for years, families living with anticipatory grief, an unknown future, basically is what that is. We've got an entire program on grief and the different types and kinds of grief. If you go to the YouTube page and in our search, type in grief, that'll come up. Let me see. Are there CEs for attending this presentation? Yes, Jamie's going to send out a email later today. Hopefully she's got good internet connection. She's in Colorado, but she said that she would send all of this out later today. Is vascular dementia progressive? Yes, it is. Vascular dementia is progressive. Typically, what we see with vascular dementia is that folks will start having, if they aren't already, those little TIAs, the little tiny pinpoint little strokes. Sometimes they're so small they don't even know that they're having them. But if the vascular dementia was caused by something like high blood pressure, cholesterol, diabetes, obesity, smoking, any of those things, those can be, if they're not under control, they will just continue to get worse. Vascular is also the one that can come on all of a sudden because it can come on right after a stroke. All of the other dementias are going to come on over time. Now, sometimes families say, nope, they were perfectly fine, and then they had that surgery and they came out of anesthesia with dementia. They already had it, but anesthesia, general anesthesia, will push it to that next level. That's with everybody. So general anesthesia is one of the worst things we can do for our brain. So we've got to always ask if there's another way to do it, or if we can have the minimal amount of anesthesia. Thank you so much for all of the very, very nice comments in there. I appreciate it. If you're not familiar, we've got about 2 minutes left with our support groups. We've got an online support group that meets every Wednesday from 1, usually to 2:30. Sometimes I have to cut it off at 2. And that is a big group. We average 30, 40 people sometimes. You're welcome to come on to that. And then we have an in-person group that meets from 11 to 12 every Friday. I'll have Jamie send more information about that also. Thanks, everybody. Be looking for an email from Jamie either later today or tomorrow. She doesn't have great internet service, so we'll see. All right. Thanks, everybody. Bye-bye.